Hello, everyone. I'm Dr. Steve Karstensen with Implant Practice US, a MedMark Media publication. Welcome to a live presentation and Q&A with Dr. Erin Nazarian. In our webinar today, we'll be exploring the step-by-step protocols for computer-guided implant reconstructions from case preparation to final delivery. Before we get started, I would like to invite viewers to use the question box in your control panel to ask any questions. Your questions will be answered at the end of the presentation. I'm pleased to introduce our guest for today, Dr. Erin Nazarian. Dr. Nazarian maintains a private practice in Troy, Michigan, with an emphasis on comprehensive and restorative care. He's a member of the American Academy of General Dentistry and a diplomate in the International Congress of Oral Implantologists. Dr. Nazarian is a clinical director of the Ascend Dental Academy. He's conducted lectures and hands-on workshops on aesthetic materials and dental implants throughout the United States, Europe, New Zealand, and Australia, and has published his articles in many of today's popular dental publications, including our very own Implant Practice US. I'm pleased to welcome Dr. Nazarian.
Good evening and welcome to this evening's webinar. Hi, I'm Dr. R. Nazarian from Troy, Michigan, and this evening we'll be talking about computer-guided implant secrets revealed. These are the types of problems that patients are presenting with in today's society. Whether it's one tooth that's missing, a full edentulous arch, or a full dentition that's non-restorable, we're starting to see this prevalent in practices all over the US. Well, there's a few reasons why. We have an aging population that's living longer, and according to the literature, age is directly related to every indicator of tooth loss. So as people mature, we start to see they start to lose teeth, whether it's due to their medications, whether it's due to wear and tear, or that they just are unable to have the dexterity to take care of their teeth. There's another population of patients that is growing exponentially, and these are the patients that either have very bad oral hygiene or suffer from substance abuse, or in fact drink a lot of sodas and pops that have a lot of acidity to them and cause this type of condition to their dentition. So these are some of the other reasons for full mouth extractions. Who would have thought that a patient who had suffered substance abuse and finally had his act cleaned up would finally undergo full mouth implant reconstruction, where we placed 8 implants in the upper arch, 8 implants in the lower arch, and provided full fixed rehabilitation for this patient. So this evening, my goal is to explain to you and show you step by step how we present to these patients, how we prepare for the surgical portion, and how we deliver the prosthetics in these cases. In other words, there's a huge potential for your practice to grow. Our goal this evening is to illustrate to you some of the steps that are involved to be able to implement this in your practice. What I want you to do is ask yourself a few questions this evening. Number 1, do you find that your schedule is not very full with these types of cases? Are your patients requesting one surgical appointment for their work? In today's economy, patients don't want to come back and forth 10 times to undergo this type of treatment. They want to try to have as much of the surgical portion done in one visit as possible. Do you do a preoperative workup of the case prosthetically and virtually? Again, when we deliver implants, we want them to be prosthetically driven. And so we'll talk a little bit about that this evening. Do you do your own extractions? And if so, are you grafting these areas? It's important to note, as you saw with the examples earlier in the presentation, that patients are not just presenting with full edentulous ridges. if you want to provide implant therapy, you also have to know how to extract and graft to set the foundation for these patients. If you are providing implants, are you doing it with guided surgery? Whether it's the leveling of the bone or the placement of the implants, this evening we'll talk about using guided surgery to be able to offer this type of service. Are your patients walking out with immediate fixed temporaries? There are several dentists within the radius of my practice, and when patients present to my practice for a consultation, they usually end up doing treatment with me because I'm able to provide immediate fixed temporaries on the day of surgery. So they're able to walk out with teeth, not with dentures 9 out of 10 times. So this evening we'll talk about the implant system that allows us to be able to do that in one visit. Most importantly, are you offering affordable payment plans for your patients? Because let's face it, a full mouth reconstruction is something that is not cheap. It's an investment. And so in order to make this investment, we have to make it affordable for our patients. So, are you ready to start doing these cases? Let's start. Well, the most important question is, where do we start? And if we're going to start, the starting point is the initial examination. Here we have a patient that presented to my practice, and he said that he's not happy with his smile. He's already lost several teeth at an early age, so he's concerned about putting money into teeth that are problematic and the prognosis is not very good. He also tells us that he wants to be able to smile again without embarrassment with straight white teeth. And he knows that he shows quite a bit of gum when he smiles. So as you can see from this profile shot, that he's not smiling very big and his eyes tell the whole story. Well, the first step of our new patient protocol when a patient presents to our practice is to welcome to the practice, and before they sit down and fill out paperwork, we actually give them a quick tour of the office so that they can see our sterilization area, they could see our modern equipment, such as our CBCT and intraoral cameras and lasers. But we also show them our photo room that shows the Hall of Fame, which is essentially a variety of different articles on the wall that I've written for various dental publications, including Implant Practice US. But most importantly, they see a lot of before and after photos of patients that have already undergone treatment within our practice. Most importantly, before we return them to the lobby, we see if they have any questions immediately. And then once the paperwork is filled out, we'll educate them step by step. So, like most practices, once the patient is brought back into the operatory, we collect the remaining information and we take the necessary radiographs and we take a look with our intraoral examination to find what the clinical findings may be. In addition to that, we will go ahead and capture photos of the patient. Not only will we take extraoral face shot, but we will also capture intraoral photos that, utilizing Bluetooth technology, gets transferred to the monitor in the room where the patient is sitting. In addition to that, we will capture maxillary mandibular models, and today now we can do that with virtual intraoral scanners and capture the bite. And then most importantly, if you're going to provide this type of treatment, you need to implement CBCT technology. So we'll scan the area of importance, or if it's a full mouth reconstruction, obviously we'll scan the whole mouth. These are the standard photos that we routinely take for all our new patients. We take a face profile shot, we take a retracted frontal view, and then we take an occlusal of the maxillary and mandibular arches. We identify the areas of decay, any crazed lines or cracks, broken teeth or restorations. We probe the gingival areas to see the areas of pocketing and the areas of health. We will also check any mobility of teeth or areas of wear. With these patients that need full mouth implant reconstruction, we will also identify the available bone, the areas that are already edentulous, the attached gingival areas and keratinized tissue, and most importantly, if they have a prosthesis, whether it's a partial or a denture, are they wearing it and is it fitting well? So if we take a look at this patient, let's identify some areas that sort of alarm us of what type of treatment we may offer for this patient. Number one, we see that he's got multiple areas that the teeth have already been removed, and those areas have already experienced some resorption because the bone was not stimulated with some type of implant therapy, or they weren't grafted probably at the time of the extraction. We see quite a bit of interproximal decay as well as decay at the cervical areas. We also see that he has a deep impinging bite. So we see that this may create somewhat of a complication if we're only going to restore an arch. Most importantly, when we look at the occlusal aspect, we see that he sort of has a narrow palate, but we can see the areas of decay and the areas that he has tried to restore, whether it's been crowns with root canals and cores. In the lower arch, we also see that he's got some areas of decay, some areas of bone loss, as well as cervical lesions interproximally. Looking at the right lateral view, we can see that he has quite a bit of a gummy smile. But most importantly, we see that if we were to place an implant, let's say in the area of tooth number 30, that we don't have the greatest clearance for an abutment and crown, or even a screw-retained crown for that matter, over an implant. When we look at the other retracted view, side retracted view, we can clearly see that tooth number 14 has hyper-erupted so far that not only can we not place an implant and crown in the area of number 19, but tooth number 14 would need so much crown lengthening that we would end up in the furcation area if we were trying to save this teeth. So the patient presented with a panorex from his existing dentist that he was seeing, and we clearly identified that this really is not enough information to be able to provide full mouth reconstruction. So the first thing we recommended to this patient was, in fact, we get a CBCT. In my practice, we have the Carestream 8100. This is actually smaller than the Panorex that we had there before, and clearly it allows us to not only capture 2D, but also 3D images from a 4x4 area all the way up to an 8x9 area of importance when scanning this patient. Let me show you an example of the importance of CBCT. Here we had another patient that presented for a consultation. We went through our normal shots with the camera, and clearly we saw with the retracted view that these teeth had rampant decay, and she also had a temporary that was in her mouth for a long period of time. She told us, in fact, she had done some research and she was interested in getting all on 4 in both top and bottom arches. Well, upon reviewing her CT scan at the consultation, we could clearly identify that she actually had a large radiolucency in the area between 27 and 28. In fact, upon a closer examination, we saw that tooth number 27 had some displacement because of this large radiolucency. Looking at the cross-sectional views on our CBCT from the Carestream 8100, we clearly identified that there was definitely some type of cyst that was growing, and we diagnosed this as an OKC. And not only did we see it in the lower arch, but we saw it in the upper arch. So this is just a clear example of the necessity of CBCT if you're going to provide any type of implant therapy for your patients. Here again is another example where a patient presented with irritation and pain in the number 20 to 19 area. We took a periapical x-ray and we clearly identified that he had some bone loss, but most importantly, when we took a CBCT of the area, we identified that there is something else that may be going on. This implant may have not been placed in the most ideal position, as one can see. Again, this is highlighting the need for CBCT within your office. In fact, not only one of his implants was failing, but also the implant in tooth number 31 position was also failing. Again, this is to reiterate the importance of CBCT within your practice if you're going to be implementing full mouth implant reconstruction. So, in this patient, the Panorex was not enough. We went ahead and did a full scan, and using the software through 3DDX, we actually got a custom conversion to clean up any scatter that there may be, to identify the areas to see if in fact this patient had enough bone for implant therapy, and to see if these teeth should be restored or should they be extracted. So clearly we could identify the landmarks, whether they were the sinus cavities or the mandibular nerve. We could also see if there were any undercuts of any sort. And looking at the cross-sectional view from our CBCT, we can see, in fact, this was not an easy case. If we are to implement implant therapy, not only do we have radiolucencies, but we have some severe undercuts that are present in this patient's jaw. So our goal as dental providers was to educate our patient and to give him some options. And he was frustrated with his existing teeth and said that he knew that they needed to be extracted. So our options to provide for this patient included either A, a removable denture, B, some type of overdenture, C, all-on-4, D, all-on-6, or E, parallel implants. In the lower arch, we were to either provide a removable denture, an overdenture, all-on-4, all-on-5, or parallel implants. In my practice, I like to give patients options, and I'll educate them so that they know the pros and cons of every type of treatment. The first treatment being a denture. The second treatment being dentures that may be retained by small diameter implants, or overdentures that may be retained with traditional implants. In fact, it may be an overdenture opposing some type of a fixed bridge, and that fixed bridge may have angled implants, or it may have axially placed implants. Whether they require sinus lifts or there may be enough bone height to place parallel implants, we go over all the different options with our patients and we give them price ranges. Whether it's a full fixed bridge starting at $25,000 per arch, or an overdenture that may be $9,500 an arch. We give our patients options. Also, we'll educate them with these implant information cards so they can clearly see and understand with these photos what's involved in the different types of treatment that are available. So what is your treatment plan? I want you to think carefully and decide for yourself, what would you provide for this patient? Would you try to provide crown and bridge treatment, knowing that he still has a gummy smile and a roller coaster bite? Would you try to provide orthodontic treatment to try and bring the maxillary teeth up and correct his deep impinging bite, knowing that he has a high caries rate? Would you extract all his teeth and provide upper and lower dentures and commit him to a lifetime of problems with removable teeth? Or would you try to provide him with a fixed solution with implant therapy? There is no right or wrong. There's offering the patient options, educating your patient, and providing him the treatment that's going to fit his budget. In this patient's particular case, he chose to go with fixed bridges on top of implants in the lower and upper arches. He did not want to have any type of sinus lift or augmentation, and he wanted to be able to walk out with fixed teeth. So our treatment plan in this particular case in the maxillary arch was to extract all his remaining teeth, level the bone, place grafting material in the sockets where the implants would not be placed or around the implants, and then give him a fixed bridge. In the lower arch, our goal was to extract the remaining 10 teeth, level the bone, and doing the treatment plan with 3DDX, we identify that we would in fact be placing 7 implants with 7 abutments and a fixed bridge. We identified the areas of concern, and we gave this patient this packet that gives him choices, gives him some education and some literature that talks about the different types of treatment that are available, and most importantly, gives them payment options. And in this case, we utilize the lending club to make this type of treatment affordable. Well, once the patient was approved through lending club and decided to have the treatment, we could go ahead and start with our diagnostic information workup. We could clearly see that this patient's midline was not symmetrical, and we saw that he had a deep impinging bite, so we wanted to correct these areas. We also saw that we knew that we had to raise this level, because the last thing we would want is the transition line in the aesthetic zone. In other words, when this patient is going to smile with implant therapy having a bridge, there's no way to mask that transition line unless you bring it above the aesthetic zone so that when he smiles, it's not apparent. And that's something that's very important that we teach at the Ascend Dental Academy. So if we were to say that his bone level was here, we identified that we had to bring it up at least 3 to 4 millimeters so that that transition zone would not be apparent when the patient smiled. The day of surgery, we had already done our workup. 3D Diagnostics had already had our surgical guides fabricated, and Arrowhead Dental had our temporaries fabricated. So we go ahead and, utilizing the physics forceps, we extracted the teeth by preserving the bone. In other words, the physics forceps works like a modified class 1 lever to remove the teeth atraumatically. Again, our virtual treatment plan indicates where we'll be placing the implants, avoiding the sinus cavities. So this is a pilot surgical guide fabricated by 3DDX that sits on the bone once you've reflected a flap and extracted all the teeth. So we've already created the osteotomies. We're going to level the bone. And now we will place the Engage Dental implant from Oko Biomedical. The beauty of this implant is that you get immediate fixation due to its patented auger tip. So the patented bullnose auger tip allows you to get a very nice torque when placing this implant and a very high ISQ. In other words, the implant stability quotient using resonance frequency almost always gives you a high number when utilizing this implant. Most importantly, it has a very universal connection and it allows you to do platform shifting. In fact, this dental implant was designed following orthopedic medicine, and we found that when replacing a hip, the design of this implant is very similar to the design of orthopedic screws, where patients are promoted to try to walk within the next stay and put some pressure, not overloading the area, but putting some pressure on their hips. So we have in fact found the same design is utilized with the Engage and the whole Oko Biomedical line to be able to facilitate load and having the patient walk out with fixed temporaries. Here we can identify that utilizing our Ostel, we were able to identify that in fact on the day of placement we had a reading of 69 on the ISQ. And when we look at the ISQ scale, we can clearly see that you can in fact do early loading. This is a very objective reading. This is not subjective or guessing or somebody just tapping on the implant and saying, well, this seems like it's fixated and it's solid. So there's actually over 600 or 700 papers now on scientific papers and reports on the validity of the ISQ and using resonance frequency in determining whether these implants should be loaded. In the lower arch, we followed the same routine where we utilize the physics forceps to atraumatically extract the teeth, place our pilot surgical guide onto the bone once the tissue has been reflected, and in fact, we checked the lower implants and found that there was in fact a high ISQ as well. So the patient was actually able to walk out with fixed provisional restorations. This is at the 2-week post-op. The sutures have in fact dissolved, and the patient is very pleased with the provisional restorations that he has. When we take a look at the provisional restorations, we can see that already the patient's smile is a broader smile. He doesn't have a deep impinging bite. And in fact, the patient feels much more confident with his smile. 4 months later, we're able to go to the final restorations. And as you can see, we go first molar to first molar for the most part with the restorations. These were cement retained restorations on custom abutments. You can see the profile of these restorations is very slim, very natural, according to the MISH classification. The upper arch, we had an FP3 restoration, and in the lower arch, we had an FP2 restoration. So at 4 months, the patient was totally completed with treatment. Not only was he able to walk out with fixed provisionals through the whole healing process, but with the final restorations, he's able to function and smile again without hesitation and without having any issues. When I talk to patients and I show before and afters of previous patients, I always let them know that the eyes don't lie, and you can clearly identify when a patient is pleased with treatment. So in today's society, if we want to provide this type of treatment, there's a few areas of interest. The first is the implant. Patients, again, do not want to come back and forth multiple times for treatment. They don't want to walk out with immediate dentures. So today's society demands an implant that is cost effective, and we want one as dentists or dental providers, something that's cost effective for us so we can pass that savings on to our patients. We also want an implant that doesn't require multiple steps. And the Engaged Dental implant from Oko Biomedical is one that easily can be placed and doesn't require multiple steps to place. It's very easy to be learned, and we teach this at the Ascend Dental Academy. And we'll share with you at the end of the presentation some incentives for our viewing public to see. Most importantly, our society wants an implant that can be immediately loaded or at least provisionalized. We as dentists want that to be at least progressively loaded or immediately loaded. We don't want to have a separate tapping procedure. We want an implant that in fact is self-tapping. We also want an implant that can be used in any type of bone. So I don't want to have a huge armamentarium of different implants for different types of bone. I want one implant that can do it all. And we want an implant that has multiple restorative options, whether it's fixed or removable, whether you prefer to have your fixed restorations cement retained with custom abutments or screw retained with multi-unit abutments. Here we see the packaging on the Engaged Dental implant from Oko Biomedical. And for under $200, not only do you get the implant, cover screw, and extended sleeve for your healing cap to turn it into a single stage healing cap, but you also get the implant analog and impression post that also acts as a temporary abutment. So let's take a look at another case. This patient presented to my practice dissatisfied with her smile. In fact, some of her teeth were already loose and starting to hurt. And she told me, "Dr. Nazarian, I would like to have a beautiful smile again, something that's straight and white, and something that I could feel very confident about." So, as presented earlier this evening, we go through our scenario of capturing our 4 standard photos. And those photos include the full face profile shot, the retracted shot, and our maxillary and mandibular occlusal views. So when we capture these photos, it is automatically Bluetooth to the monitor in the room. And the interesting thing is most patients will comment that they're surprised of what they see, and they actually question, is that really my dentition or is that really my mouth? At the initial appointment, once we've captured these photos, we will also capture models and a bite and a CT scan of the area. We'll identify any caries and craze lines. We'll do our periodontal charting and check if there's any bleeding on probing, any areas of mobility. We'll also identify the areas of bone loss, keratinized tissue, and if in fact they're wearing their prosthesis. So upon closer examination, not only do we see the wear, but we can actually see the abfractions. So we know that this patient is in fact someone who may clench or grind or have some type of parafunction. Looking more closely, we can identify the areas where she has some root tips that are starting to come out of the tissue. So in fact, they're only being held by gingival tissue, for example, in the number 14, 15 area. So before we do anything, it's imperative that we capture a CBCT. As mentioned before, I utilize the 8100 within my practice, and we can clearly identify that although we may look at a Panorex view and say this lady has tons of bone, we can clearly identify that she's got some severe undercuts on some very narrow ridges. We utilize 3DX to get a custom conversion, and clearly we can identify in the number 11 position how advanced the bone loss really is. We review the different types of options that are available for this patient. In the upper arch, we review the options from removable denture all the way to axially placed implants. In the lower arch, we also offer her a variety of different treatments, whether it's starting from removable dentures to overdentures to all-on-4, all the way to parallel implants. After reviewing the different payment options, the patient decided to go with Lending Club to help assist her to make this more affordable. We decided that we were in fact going to extract all the remaining teeth, level the bone, graft these areas, and the same day place our engaged dental implants with temporary abutments and then place fixed bridge. This is what our goal was. So looking at the virtual treatment plan, you can see our implants. We can see that in fact in the lower arch, we will need to do quite a bit of bone leveling in order to get adequate width. So we identify this virtually before we even touch the patient. When starting with these cases, we'll always start with a diagnostic model. And the nice thing with the Silginat from Kettenbach is that our assistants don't have to pour them up immediately. So essentially you're getting a polyvinyl impression for the cost of alginate. We're identifying the areas for our dental laboratory so they may in fact identify what type of provisional restorations we want to provide for our patients. So here I'm identifying where we'll be leveling and where in fact we will have our provisional restorations extend to. We usually will just extend first molar to first molar. The day of surgery, not only do we have our surgical guides available, but I always have two types of provisionals. I will always have an immediate denture just in case the quality of bone is not the most ideal and I can't load the implants immediately. If I can load the implants at the same time, then I will in fact offer the fixed provisional restoration. In the lower arch, we can see that a lot of reduction was necessary. So we have our bone reduction guide from 3DDX, as well as our surgical implant guide. We have our immediate denture, and we have our immediate fixed provisional. So the day of surgery, we have everything ready. We utilize IV sedation within my practice to sedate this patient and be able to offer this treatment all within one appointment. We atraumatically extract all the teeth utilizing our physics forceps. Then we reflect a flap so that we can place the bone level guide on top of the bone, not on the tissue. I feel that it's much more accurate to place our surgical guide on bone as compared to tissue. And obviously these teeth were too mobile to try and keep these and sequentially place the implants. We review our custom conversion, and again, you can clearly identify the area with severe resorption. This is what it looks like once we've reflected the tissue. And you can identify the areas that we've leveled. We place our surgical guide onto this area, and utilizing our guided surgical drill kit from Oko Biomedical, we sequentially do our osteotomies and place our engaged Oko implants. You can see here, I like to place the implants free-handed following the osteotomies that were created. Sometimes placing the implant through a surgical guide may give you a false sense of fixation, so I like to freehand these into the osteotomies once they've been initiated with the surgical guide. And because the quality of bone, even using the Oko Engage implant, was poor, we did not have the most ideal fixation. So in the upper arch, we went ahead and provided an immediate denture. And we soft relined this with the Tokiyama soft reliner, and I like to use the medium. Another nice soft reliner is the one from Kettenbach, also called Mucoprin. So they all work very, very well. In the lower arch, we went ahead and extracted the lower teeth, atraumatically utilizing the physics forceps. And in this case, we used the Smart Dentin Grinder to use it as an autograft and use this around the implants once we were to level the bone. So here we've extracted all the teeth. We have our dentin graft ready and available, and now we place our bone level surgical guide and reduce necessary bone so that we get ideal width. We place our surgical guide now to make the osteotomies for the implants. Again, I really like the Engage implant because of its immediate stability. So utilizing those with stock abutments, we place the graft around our stock abutments and cover this with a membrane, suture this, and now utilizing the Engage dental implants, we had recorded a very good ISQ using the Ostel. So we knew that we can go ahead and place a fixed provisional on these implants. And the lady left our practice with an upper denture and a lower fixed provisional. This is 1 week post-op. You can see the difference in her smile already. We had a little overgrowth of our gingival tissue, so we use our Picasso laser to just laser that. So these were stock abutments used and placed once. We prepped these stock abutments once the tissue had healed after our laser treatment. And using our Panasil impression material, we took a full arch impression, and our laboratory fabricated our FP3 restoration. When cementing these restorations, I like to use temporary cement so that if I need to retrieve them, I may. The other important thing to keep in mind is when you are using cement restorations on implants, you don't want to fill or overfill these with cement. We want to just have a thin layer. We want to avoid peri-implantitis caused by placing too much cement, whether it's temporary or final cement. We never want to fill the restorations with that much cement. And so here you can clearly see the gingival health. So we were actually able to go to final restorations within 6 to 8 weeks in the lower arch. In the upper arch, we obviously wanted to wait a little longer. And here we clean any excess cement with our scalers, and we review the oral hygiene instructions with our patients. And here we see our upper denture. At about 5 to 6 months, the upper arch had healed. So our goal was to go ahead and check these implants to make sure that they are ready for the final restorations. So again, utilizing our Ostel and ISQ, we recorded, and we found that in fact we had a very high reading with our ISQ. So utilizing our Panasil impression material from Kettenbach, we take our full arch impression and bite, and here we have our final restorations. These are FP3 restorations according to Dr. Mish's prosthetic classification. Here we have the occlusal aspect, as you can see. So these are cement retained restorations. In the upper arch, we use custom abutments. In the lower arch, we use stock abutments. Again, we use temporary cement so that if we have to retrieve these restorations, we can easily use the pneumatic crown remover from DentCorp and tap and remove these if necessary. Here we can clearly identify that utilizing some of the techniques that you've learned this evening, we may be able to assist our patients and rebuild their self-confidence, rebuild their function, and rebuild their aesthetics. I welcome you to log on to ascenddentalacademy.com to review some of the different courses that are available. Our courses are provided not only by me, but by mentors that practice in everyday life. And so we want to bring some of these techniques and skills to our members. This weekend, we're actually doing our Level 4 in Schaumburg, Illinois, where our mentors are actually going to be placing all-on-6 after they extract level bone using guided surgery, and then place 6 implants with a fixed provisional restoration. I'd also like to invite you to our mini residencies 1 and 2 in Phoenix, Arizona on October 6th and 7th, and also our mini residency 3, where we talk about all the different fixed options that are available with guided surgery in Las Vegas, Nevada, November 3rd and 4th. I would like to, let's go ahead and open up our conversation to questions that I'd be more than happy to answer.
Well, thank you, Dr. Nazarian. I do have some questions before I get to from the audience, but before I get to those, certainly, audience, if you have some questions, type them in your question box, and let me make sure I'm able to get to those. So, okay, here's a few from the audience here. Would you say a little bit more, please, about the treatment options, including, you mentioned we have these implants and we have parallel implants, and I'm not sure I got the difference between what you mean by these implants and parallel implants.
Sure. So if we're talking about a parallel implant doesn't have a taper. So when implants don't have a taper, they don't have as good fixation because you're placing a parallel implant into a parallel hole. So that's one of the areas where I think the literature shows that a tapered implant works much better. What I found in particular with the Engage Dental implant from Oko Biomedical is that in fact it has a patented auger tip, a bullnose auger tip that not only engages the bone but pulls the bone in at the final 3 rotations of this implant when placing it into the osteotomy. Excuse me. Most importantly, you have V threads that change into square threads, and the implant fixates very quickly because of the aggressiveness of the thread pattern and the pitch, but also because of its patented auger tip. And this is one thing that we teach at the Ascend Dental Academy. I've had the opportunity to try at least 18 different systems, and the Oko Biomedical is the implant system that I've chosen to teach exclusively at the Ascend Dental Academy after having an opportunity to place a variety of different implants.
I was going to say, over the years, we've certainly seen a lot of different designs come and go and be, you know, the be-all, end-all. But I see this Oko Biomedical dual stabilization as being kind of a combination of lots of different ideas, the V threads and the square threads and the taper. So it's using the best of everything, it looks like.
Yes. In fact, the creator of this, Dr. David DeLeese, has been in implantology for over 40 years, and he's been one of the pioneers in immediate stabilization and immediate load. Before it was you know, mainstream.
Okay. So another question from the audience: go over the instructions again, please, that you give to patients about tissue health throughout these appliances, because it looks like you covered a lot of tissue and there's implants underneath there somewhere, and I saw the slide about Superfloss, but can you go over that a little bit more, please?
Yes, absolutely. So what I tell my patients is you need to protect your investment, and so we need to see you every 3 to 4 months for oral hygiene, to clean underneath these structures and to get professional cleaning, because if you're not protecting your investment and you're not cleaning these prostheses, whether it's fixed or removable, then the longevity is not going to be the greatest. The analogy I use, since we're in the Motor City here in Michigan, is whether you're driving a little Chevy Sprint or a Cadillac, if you don't do the basic and change the oil and take care of that car, just because you paid $60,000 for the Cadillac doesn't mean that now you don't have to change the oil or take care of it. And the same is true for your mouth. So I think the patients have a vested interest once they've spent this type of money on these reconstructions. So we found that most of our patients, in fact, come back for routine oral hygiene to protect their investment.
Okay, let's add a couple of financial questions then. In fact, stemming right from there, do you talk a little bit about post insert like care? Do you cover the first hygiene visit, follow-up care with the same fee, or is there additional fees? And a doctor from Dallas asks, are you charging a fixed cost per arch for the rehab, no matter how many implants you use, or are you charging them for each one? Do you charge for both the immediate denture and the fixed PMMA provisional? Kind of, I guess we don't want to ask you specific fees, but just kind of philosophy about those things.
Sure. No, I like to bundle. That's a great question. I like to bundle my fees and not nickel and dime my patients on every little step. So if it's going to take 2 or 3 temporaries to get the final result, I'm not going to nickel and dime the patient on it. Routinely, I charge $25,000 to $30,000 an arch, and that includes the extractions, grafting, guided surgery, provisionals, and final restoration. Now, if I find that the patient may have a complicated situation, then that may be closer to $30,000. If the patient comes in and they're totally edentulous, then obviously it may be more around $24,000 to $25,000 in cost. So I give them a range, but the ranges that I give my patients are bundled ranges. And whether it's 4 implants or 6 implants, my price is still the same.
Well, that certainly sounds a lot more comfortable going into it, so they don't have to worry about, did you just place more implants so you could charge more money, kind of a thing. So exactly. It's really building a trust relationship with your patient there too.
Yes, yeah. And my goal is if I can place more implants, I will. I believe in the teachings of Dr. Carl Misch, and he routinely would talk about biomechanics. And if we can place more implants into an area, especially with the Oko Biomedical implant being under $200, and there's several implant systems out there under $200, what's it going to cost to us to place 1 or 2 more implants? Is that worth the investment and the insurance to maintain the longevity of the prosthesis? And I say absolutely.
Yeah, and that actually leads nicely to the next question, and is why not use screw retain instead of cement retain? Wouldn't that allow you to clean better and kind of protect that investment a little bit differently? So say more about that, please.
Sure. So there's 2 trains of thought with cement retain and screw retain. They both have their pros and cons. The pros with a cement retain restoration is utilizing custom abutment. You don't have an access opening that's going to stain and discolor or possibly cause some type of fracture. With the screw retain restoration, the pros obviously are the fact that you can retrieve it much easier. However, the access openings, patients don't like to see a composite, and even though you make match the restoration, whether it's acrylic or porcelain to metal or even zirconia for that matter, 2 to 3 years later, those areas of composite may stain. Sometimes these areas can cause areas that may be weaker depending on whether you're using a hybrid or not. And also, the profile prosthesis in a screw retain restoration sometimes can be much wider and larger. And so sometimes these patients go, I want a bridge on implants. I don't want a fixed denture or hybrid denture. So I give the patients an option. So I do a variety. I would say I probably do 60 to 40 fixed with cement restoration, 60% to 40% screw retain. But whatever the audience is comfortable with, I say go with the restoration that you're most comfortable with. And I think that's probably the best. If you're comfortable providing screw retain restorations, I say keep providing it. If you're comfortable providing cement retain restorations, then you can provide that. If you are going to provide cement retain restorations, then make sure you don't overload the restoration with the cement. Make sure you use temporary cement. And most importantly, if you're going to use a stock abutment, make sure the margin is at or above the gum line. And if you're using a custom abutment, now with all the abutments that are available, whether they're Atlantis abutments or CAD/CAM abutments, make sure the laboratory is not submerging these way below the gum line. And the studies show that if you keep that margin superficial or right at the gum line, you're not overloading with cement, then in fact you can still maintain a very healthy restoration. And it's still retrievable if necessary.
Well, that is really excellent material. So thank you everyone for your questions. We unfortunately run out of time. So if we didn't get to your question, we'll certainly answer it after the webinar via email. If you'd like additional information about Ascend Dental Academy, please be sure to download the brochure attached to your GoToWebinar control panel, PDF right there. That'll give you contact information and much more about Ascend. We also have included a link to their website, which is www.ascenddentalacademy.com, within your chat box there, so you can see that. In addition, as a thank you for attending, we'll email you a special promotional code to save over $900 to Dr. Nazarian's Module 1, 2, and 3. So what a great deal. Thank you all again for attending this webinar, and a special thank you to Dr. Nazarian and our sponsor for this webinar, Oko Biomedical. Thank you. Have a good evening.
Thank you and have a great evening.